Hey guys, welcome back. We have a pretty impromptu, fun episode today. I was just chatting with, virtually chatting with Amir and Joe, and we were thinking about what people want to hear and what we like to talk about and things like that. And we kind of came up with like cool instruments that we use for certain things, complications in oral surgery. So we have today actually two guests. We have Amir and Joe. And you guys want to just quickly introduce yourselves to everyone? Everyone knows Amir, I'm sure already. You're up, Amir. Let's go.
Well,
you're up.
I'm Amir. I'm the Real Tooth Doctor on Instagram. And,
AKA Real Tooth Doctor.
AKA the Real Tooth Doctor.
Other Dos Equis guy.
I practice in Toronto and Canada.
Awesome. Coolio, you're up.
Pleasure to be here with you two superstars. I'm Dr. Joe Doctora. I'm an oral surgeon practicing outside Nashville, and happy to be here with you guys.
Hey, thanks for coming out, guys. This is early for me. I'm in Seattle time. It's like 7-something in the morning on a Sunday. Take it up.
Sorry.
You guys are what, East Coast time?
We're
essentially?
East Coast time. But this
East
is like
Coast
prime time for us to do this.
Yeah, okay, I get it. That's fine. Normally for work, I'm usually up at 5-ish. You know, I start work at 7, and so I'm used to getting up at 5, so I'm up anyways, if not my freaking cat wakes me up. But yeah, so I mean, as far as oral surgery stuff, I would say both of us, all of us do a lot of extractions. We do a lot of basic procedures in the office, surgical related, and so when you do a lot of procedures, you're going to get into a lot of complications. You're going to get into some weird situations. There's like some wisdom teeth that I take out or some teeth that I take out. I'm like, even I sweat, right? Like oral surgeons can still sweat and have issues with taking out teeth. Teeth can humble you. Like you can do the most complex surgeries, but that freaking number 14 root canal erupted molar can still humble you, you know, in a lot of ways. So I think it'll be fun to talk about how we manage certain things. I know Amir has a list. You had asked some of your followers about some questions of what they have, and what did they say? Anything good?
So there was a lot of questions, but I think a lot of people wanted to know about sinus perforations and how to manage them. I think that's like a really good one.
That's a really good one.
Dry socket.
Yeah.
Management of bleedings, ankylosed roots.
Okay, those are good. Meaty.
Dislocation of an impacted upper wisdom tooth into the sinus.
Yeah.
That's a good one. A lot of dry sockets again. A lot of bleeding.
Like bony sequestrations, bleeding, you know, all the stuff we're going to see, tuberosity fractures. Yeah, let's get into all that stuff. This is going to be good. So hope you guys get a lot out of this. This will be kind of fun for me and hopefully for you guys too. Right away, so I actually have a bunch of instruments on my desk here. I took a whole extraction tray from my office and I just have it at home. And basic instruments. I know Amir and I talked previously about he likes to section a lot of teeth. He doesn't use a ton of forceps on a lot of teeth. Everyone, you can ask 10 dentists, 10 surgeons, periodontists, whatever, and they can tell you 10 different ways to take out the same tooth. And you can all get to the same result. You know, there's no one way to do it. I just still recommend, you know, do what works for you. Try different ways to do things and then see what works best in your hands. And that really makes the most sense to me. Does that make sense to you guys too?
Absolutely.
Joe, do you use a lot of forceps? Do you use section all the teeth? Like, what's your deal?
When necessary, you know, going back to what you said just yesterday about, you know, getting humbled. So I've got a very good referral, and he brings his son in kind of impromptu before he starts school next week. So my policy is I don't like to have anybody watch me take out teeth because parents may become, you know, what they see, they're not used to. But anyways, he's a dentist. He refers to me. I look at these teeth. I said, yeah, should not be a problem. He's 20 years old. And I kid you not, number 17, it took me 40 minutes to take out. And he's
Were the parents watching you?
Yeah, the dad was watching me. And you know, when I'm done.
Do you get a little sweat on your back?
Pretty much. And I never say, hey, this is going to be easy. But before the case, I reassured him and I said, hey, he's 20. It shouldn't be a problem. I'm thinking to myself,
you just jinxed yourself. When you say stuff like that, 100%. Like in my mind, I jinx myself. And sometimes you're doing a case, and I'll let you get back to your story real quick. You're doing a surgery, you know, you're like on the fourth wisdom tooth of the case, and the assistant may say, hey, this is going great. And then you break a root on that one, and then you're like chasing it, and it's like 30 minutes later, you're still trying to get it out. So you can totally jinx yourself. I believe in that stuff.
and I never do it. But with him, my mouth was just acting hyperactive for whatever reason. So, anyways, what happened was, when I was horizontally sectioning the tooth, and it was mesiodistal impacted, and you go 2/3 through, you snap the root, but it didn't go all the way through, and there was that little strut of bone, of tooth against the bone, so it won't let you rotate the roots out. So I just had to break off that little last piece of the crown, and I was able to roll the roots out. But it took 40 minutes, and I was sweating. And
Sometimes
the dad was
they're
watching
so
me.
tucked in. Yeah, they're so tucked in there. Like you had an incomplete section on a mesioangular impacted.
Yes.
And so when you do that, that distal crown comes off, but the roots are still attached to each other, right?
The roots are still attached, and there's that little piece of crown that you try to, it's tricky because you don't want to section all the way through and then get to the bone and potentially have lingual nerve damage. So I
Right.
just try to score it and chip it, and you just try to go from every angle, and I finally got it, and it came out nicely, and it was fine.
Was it a horizontal impaction or was it a mesioangular?
It was mesioangular, but completely horizontal.
I see, okay.
So horizontal.
It was a horizontal impaction. Yeah, exactly.
And the piece of tooth you had left, was it close to the lingual plate, or
Exactly
was it...
right. It was just
Yeah,
a
I
little tiny strip. But that little tiny thin strip will prevent you from rolling out the roots unless it's completely
Enamel's
separated.
Tough, man. Yeah, enamel's
Exactly.
tough.
And he had tough bone as well. And part of that was the anesthesia started to wear off, so I had to make him deeper, and it was that whole balancing act.
And then they're bleeding a little bit more, and it's just hard to see, and everything
Right.
gets real frustrating all at once. Like a little
Kind
bit
of.
of blood or something in that site really makes it difficult.
And my assistant laughed, and I just said, "Yeah, that's the hardest tooth I took out in 6 months." And of course, there's a dentist watching me take it out on his son. But
It
it's
happens,
fine.
yeah.
Yeah.
Yeah, so like wisdom teeth like that, you find in a lot of cases, erupted teeth are harder than impacted wisdom teeth, to manage and take out. Do you guys think that, or do you think impactions are still tougher?
I literally say that to many new dentists, like every single day, because they're like, oh, well, you do all these complex impacted teeth, so this is going to be a walk in the park. I'm like, that root canal treated first molar with like the roots being in the sinus, and there's a post and an amalgam core in that. I'm like, that's going to be one of the toughest teeth you'll ever take out in your life.
Yeah. Those things are frustrating, especially if you're trying to preserve the site, so you don't want to remove a ton of bone. And there's like lots of factors there, for those teeth. I think they're super frustrating. What about you, Joe? Do you think impactions are tougher, or like in general?
Oh yeah.
Or erupted teeth?
A lot of times, erupted teeth. I'll get a treatment plan that says take out, 4 wisdom teeth and then 1 second molar.
Yeah.
And I know the second molar is going to be the toughest.
I know, that happens all the time.
All the time.
You're taking out 4 wisdom teeth and then 1 rando tooth, and it's that rando tooth that freaking takes forever.
Right.
And they're not numb enough at that point, or something else is going on. It's just frustrating. I get that. That's so funny. So I'm not alone in that, I guess. So let's just say, Joe, you're taking out an upper 14, like we're talking about. Endo treated 14, and like Amir said, its roots are in the sinus a little bit. You take it, by the time you get everything out, there's like a 4 millimeter sinus opening. You can see the membrane, but you don't see a perforation. How do you manage that?
I'll put a stitch in there, but I won't close it primarily, just because that's unnatural, and nor will I pack it. I'll just put the gingiva together, and I'll give the patient sinus precautions. And I'll just
so
tell
what
them,
sinus precautions are you telling them?
tell them, avoid straws, avoid any sort of sucking motion. If you smoke, stop, don't do it. And I'll even ask them, I say, hey, if you feel a sneeze coming down the pipeline, just do your best to stop it. Just kind of rub your nose and prevent that. And do that for a couple weeks. And I think the clot ought to mature, and you should be out of the woods by that time. But
Do you have any
educate the
issues with
patient.
that without plugging it? Because I know a lot of people, they don't know what to do, or they ask me, how do you manage this, blah, blah, blah. So if that works for you, that's awesome. What I usually do in those cases, I'll put a collar plug or something like that in there, and I probably still don't close it primarily if it's like a 3 or 4 millimeter defect or an opening. Membrane's intact. I put a collagen in there, and then if I get a little bit of closure, that almost maybe halfway, 3/4, I feel comfortable with that, with sinus precautions. And like the main one I always go over verbally, it's in our sheet. I say, don't blow your nose for a couple weeks, like 2 weeks, try not to blow your nose, and that's going to kind of keep the airway open. If you sneeze with your mouth open. Don't block the sneeze, because if you block the sneeze, you're going to stop the you're going to backflow the air going back in there. So those are the two things I verbally tell them, and it's always in the instructions, but I make sure I go over those two things because I've seen failures from people with allergies and things, and all they do is they blow their nose all the time. And if you don't tell them that, they don't even think about it. They just still do it. And they'll just blow up your little closure there. So I guess in those cases, that's not even a simple closure. That's just basically putting a little collagen or hemostatic dressing in there. What about you, Amir?
I predominantly use collar plugs. I put a collar plug in, and then I'll probably use like a fluorochromic. I won't suture it like primarily closed, but I will put crisscross sutures across to kind of really stabilize that clot. And also I want it to prevent packing of food in there. So I find like in the first 4 or 5 days when you use the chromic, it's got like a lot of tension and it holds things really good in place. And then I just give them the sinus precautions and all that. And then I usually put them on amoxiclav just as a precaution because sometimes there might be a small little perforation and you don't see it. And
sinus fluid is kind of irritating to the gingiva. It's different. If that kind of seeps in there, that does cause issues with pain and stuff too. So if you're taking out that number 14 and now there's like an 8 millimeter opening with perforation at this point, is that you guys manage that the same?
I don't.
Joe?
I probably would. 8 millimeters, that's a big one. That's a big.
Yeah, that's good size.
That's pretty good size. So I probably would do a bilateral vertical releasing flap and advance the buccal tissue and then close it primarily, and then give the sinus precautions. So with 8 millimeters, that's pretty significant. But I still reassure the patient that to come back after the fact and to repair it, a fistula is pretty uncommon.
Amir? I think what Joe just did was a simple sinus closure, right? So you do a buccal flap, basically. I think the coding is simple sinus closure for that, essentially. And then do you do the same thing or something more extensive?
It depends. It depends on the patient. If I can access that fat pad like easily, I might take a little bit of fat pad and then do a closure over it. Mm-hmm. But if it's if I have like a good thick alveolar bone over the sinus, I might just do what Joe does and just keep things simple and do a buccal advancement flap and just suture it closed. And if it's like if I think it's a really, really, really high complication one, then I might just refer it out.
Yeah. So I would, for like an 8 millimeter opening, it depends. If I feel like I can get that tissue with the buccal flap and some collagen in there, and I feel like they're kind of compliant with instructions, I would feel good about that. It just depends on the patient. If I feel like they're not compliant or I don't get that good feeling, if they're a smoker, other things, I will probably go for the buccal fat pad. In that case, we just code it as a complex sinus closure. Kind of go distally, find that buccal fat pad, tease it out, put it into the site, suture it over it, and then suture the gingiva primarily over that. The issue with that, though, is you lose some of that vestibular depth when you do that. I mean, it's a trade-off. There's ways to correct that down the line, but that's the trade-off sometimes is you lose that vestibule a little bit in that site. But the goal is to close the sinus first, and then you can deal with that stuff later, in my opinion. So, yeah, so that's complex sinus closure. But yeah, if you're not comfortable, if you're in a dental office and you're taking these teeth out and that happens, you really got to have a protocol in your office with like a sinus precaution sheet on your website or something else that you could, go over with the patients and then manage it a couple ways, whatever makes sense to you, or refer them out, obviously, at that point. But erupted teeth near the sinus, things like that, you got to always account for the possibility of that happening. So that's a big deal. What about bleeding? Go ahead, Joe.
One thing I want to add to that, Serv, if we're talking to a lot of people who are in offices doing what we do, is that the likelihood of that happening is much higher if you're taking out, for example, 14 and 15. If you do 2 consecutive teeth in the sinus, the chances of that happening are exponentially higher. So kind of beware, if you're new and you're starting this, look at your x-ray and find out what you're doing and be prepared.
So 14 and 15 are first and second molars, basically.
Yeah.
Because I know the numbering system is weird everywhere. But what is it in Canada? What are those teeth?
We use FDA.
I know.
So it'll be like 2.6 and 2.7.
US is weird.
You guys just like to do everything differently.
It's weird.
Right.
Yeah, it's weird. Yeah, so that's Yeah, I agree with that. Two consecutive teeth in the upper part of the back maxilla, posterior maxilla, are more problematic. And I actually go over that with patients. Like, if there is a sinus opening, we may stop at this one and then deal with that rather than deal with the ginormo opening. I've done that in some
I've
cases
done
where I
that
think
too.
that might happen.
But if I get into a sinus on the first molar and the premolar is treatment planned, I'll leave it in until next time.
Yeah, because you can obviously that little piece of bone bridging them will probably be gone by the time you take out the other one, and then you have a much bigger opening, higher risk of fistula formation, and harder to close really. So I agree with that. So let's see here.
I learned something new today.
Yeah. So I mean, do you guys have a favorite elevator or something you use on teeth?
Joe?
Joe? Yeah, go ahead, Joe.
I think we've had this conversation, all of us, of the most common questions in our DMs, and mine is what elevator is at, and more often than not, it's the 77R. But I have discovered the EL3S, and that is it's
This
more
is
of
a
a
77R. It has like that bend in it
right.
and a concave side, and it really helps getting back with those molars because of that angle. Everyone, 100% of people should have this in their set somehow, like something like this. I agree.
Yeah, and if there's one drawback that I found to that instrument is the fact that the head sometimes is a little thick. So sometimes getting into those tight places is difficult. It really is, especially if those teeth are really locked in. So this new instrument that I'm turned on to is the head is thin and it's pretty durable. So I've broken tips before, and you're able to get in tight and then and remove it.
What's the name of that instrument?
It's called the EL3S, and
EL3.
I think there's also a version called the EL3C. No, I'm sorry. Hold on. EL3S and the EL3C. And I think it's made by Hugh Freedy.
And there's an offset like the 77R, but the tip of it is shaped differently.
I believe so. Yeah, check out your catalog. But I think the 3C has got the offset head, and the S is straight. But I tend to reach for that a little bit more than I have in the past, just because I don't know, I've just gotten a lot of tight contacts between teeth lately.
Yeah, I mean, what I usually start with before the 77 in a lot of cases is the spade, and it's offset and it has a little thinner and a pointed, tip to get into those spaces and create a little widening. But then you can get your wider elevator in. So I usually start almost every tooth with the spade. I haven't seen the one that you're using, but I'm curious to see what it looks like. I'll look it up later. And I'll throw it on for the shorts, but that's what I like to use.
Do you find the spade has enough strength at the tip for the lower mandibular teeth?
Yeah, it's not your primary elevator in a lot of cases. It's the starter. Like I think of it as a starter. Like like when when the anesthesia is intubating someone through their nose, they don't go with the widest tube. They put the little tube in for a little while, then they put the little bigger tube in. The cannula, the little nasal trumpets, before they put the endotracheal tube in that's widest. So in case of elevators, I'm always starting with something I can just open up that space with a tiny bit, even if it's a solid tooth and it's not moving. If you can kind of get it in there and wedge it, like dentists do with those little wooden picks between teeth. What are those called? Wedges?
Yeah.
I don't remember.
Restorative dentistry.
What do they call those things? Wedges?
Yeah, wedge.
Oh, okay, all right, I remember something. They put them in there to, separate while they're doing a restoration, right? And then you take them out at the end, right? And the tooth just goes kind of slowly back where it was. So I'm thinking it's the same thing. You kind of wedge it in there and you kind of create a little bit of space for the next more, robust or thicker elevator that you want to throw in there. So sometimes teeth just don't move with them. Obviously, you just go right to sectioning. But in a lot of cases, I try it that way first. Because even if you get it to move a little bit and the roots break, I feel like if the roots already have a little bit of movement from what you did before, it helps to get them out versus them being solidly ankylosed, or just bonded to that bone. Does that make sense?
Yeah, absolutely.
100%.
Yeah, so the spade is what I like, and I don't know, Amir, what do you do?
You guys nailed both of them. I use the 77R 95% of the time, and that spade I use very often. I also always have like one very thin luxator. I know you're not supposed to use them as an elevator, but
I mean, yeah.
But I do, especially with those cases where like the root's completely ankylosed. You know, like back in the day, they used to use like the hammers and the little wedges.
Chisels and
Just
ceotomes
chisel
and things.
chisel
Yeah.
the root. So I use that literally like a chisel. I'll just try to wedge it in between the bone and the root until I can get it deep enough in there and just give it a few twists so I can see maybe a little bit.
Are you using a
movement.
mallet? Are you malleting it?
No,
I've done that sometimes too. I've had to do that sometimes too. I put the spade in sometimes on lower wisdom teeth that are really down there, and you can't just, they're so tucked into that second molar, it's hard to even get an instrument in there. I put the spade in there and I got a mallet, and I've actually malleted the spade to where I wanted it. And once it's in that little spot, I can kind of start rotating a little bit more and then so I've done that. Because the way that these spades are, they have a fat handle. So you can,
But
can
you
put
do
it
that
on.
on a patient that's under GA.
not necessarily.
No, you
sometimes
don't.
you're going to feel a little, it depends, sometimes because, when you're doing those indirect sinus lifts before, all the densification burrs, we were a lot of times tapping up there for various reasons. So, sometimes you got to do what you got to do. I tell them it's less invasive than me drilling all that bone out, which it actually is. It just feels freaky,
Amir, do you ever get into a situation in one of these offices where you need something really specialized and then it's not available?
On a daily basis.
Oh, that would suck.
Okay, let me tell you something, man. That's annoying, but I think that makes you better for sure. That's happened to me quite a bit when I used to do what you did, and it just makes you think on your feet and use what you have, and makes you better for sure.
I literally have had to do that on a daily basis. Like you do a horizontal impaction, and they don't have like a straight surgical handpiece where you can kind of extend that burr out, and they give you a high speed, like a surgical high speed, and then they've got two burrs for you to choose from, and they're both super short enough that you can't even drill 75% through the crown of that tooth. Now you get the crown out, you want to get to the roots, you don't have a long enough burr to get to the roots to section it.
They make long versions of burrs, though.
Yeah.
But I guess
know.
maybe you should carry some long versions.
I do now. I honestly, I have a whole suitcase that I take like different burrs. I even have my own sutures because sometimes you get into an office and
they're expired or something.
or they
Right.
you can't use this nylon suture for the wisdom tooth extraction. I'm like, it's probably not the best thing to use here. So
Interesting choice of having those in a dental office. Yeah, that would frustrate me. On those impact errors that a lot of people use, can you pull that burr out a little bit more and just have it still be functional, or does it just start to whip too much?
I do that sometimes.
You have to sometimes, right?
And I have no other choice, but then you run the risk of, especially in like a very dense bone or a very dense enamel,
Breaking it off.
It'll pull it out. You get a bit of tension and it'll actually pull the burr. Now, if you're lucky, the burr will get stuck in the tooth or the bone. If you're not lucky, it shoots.
Yeah, or
But
even where it went, and you got to like look around.
So I always literally, and a lot of people say, oh my God, you put a throat pack on an awake patient? Yes, I do. Absolutely.
I don't know why you wouldn't. Like, everyone's like surprised. I'm like, think of all the things that break off when you're taking teeth out. All the time. It happens all the time.
Yeah, so
I don't know. I don't get it either. That's interesting. So, I know Amir had talked before that he doesn't use a ton of forceps, but I use this one for almost every tooth. I use it uppers, lowers, it doesn't matter. It's a 962. It has these like grippers on it, and then it, serrated, like the serrated. It's hard to see, but it has like serrations on it, and so like you can grip it, for an upper tooth, lower tooth. I find it super useful. I don't use 150s or 150
is that another
ones.
rendition of the 150 universal?
I don't know. There's only one place that makes it. No one makes it except for one place now.
it's thinner, Joe. This one is like a little bit thinner, and I think the aim of it is so that the beaks get long, like deeper down into the root.
I like it.
Yeah, I use it for every tooth. I don't know how I'd practice without it, just because I use it so often. I don't ever use a 150 or 151. I haven't used them in like 18 years. But for some premolars, I'll use this ash forceps. It's pretty standard, bird beaks, whatever you want to call it. I forget the number of it. But I don't know. Do you guys use this at all for anything?
All the time. I know they taught us not to use those for upper teeth, but I do. Or double rooted teeth. I use them on first premolars all the time.
Yeah, premolars, some anterior teeth, obviously.
Yeah.
We have a skinnier version of it where the beaks are super thin, because sometimes you're taking out, a lower incisor that might be like crowded and it's like out of position, so you can't get the regular forceps or even around it. So we have these thinner ones. We call them the thin ash. So I'm like, I need a thin ash, and like everyone knows,
Yeah.
you know, we have this
We
drawer in every
call it
office.
the skinny ash, but be prepared if you
Yeah.
post that online.
Yeah,
you're
skinny,
gonna get
it's skinny ash. It's skinny
skinny
ash.
ash. You'll get messages online if you post you using that on an upper anterior tooth or premolar about how you're doing it wrong, that sort of thing. And I think sure, but practically speaking, you know, it's effective and saves time, and it really depends. There's no real wrong
I don't
answer.
think you're
in the
doing
real
it
world.
wrong. I mean, if the tooth comes out efficiently and you're not damaging anything else, you're not doing it wrong. You're just doing it a different way. And there's always caveats to ways to use instruments. I know how to use it in that situation. You know, you got to be careful. Really.
I think whatever works.
Yeah. When it works, it works.
When the shoe fits.
100%.
Yeah, you got one, Joe. You got one.
You know, but with that one, with the ash on the first premolar, you grab the crown and you apply it, and you know it's typically a rotational movement, but if you just push apically and kind of almost widen that alveolar bone, it'll get loose enough to where you can remove it. So it is a double-rooted tooth, but very effective in my opinion.
What would you guys use if you're doing an immediate implant on one of these teeth? Would you still put the forceps on?
Yes and no. So if it's a premolar, if it's single or double rooted, if I feel like I can get it out with elevating it in a forceps and not remove any bone, and it will work, I'll try that first. If not, then yeah, sectioning, preserving buccal bone would be, you know, the way to go. Joe?
I agree 100%. I would try to do it with just only an elevator, but if need be, I would put the forceps on there and just really push it in, and I think that expands your bone a little bit. And when you remove it, I think that's pretty conservative as far as preserving bone.
I mean, even if the root breaks, like I said before, in my opinion, like just the way I think, my weird mind is like, if you have it moving a little bit and the root breaks, you're still better off than just like taking the crown off and then working on those solid roots, because you have a little bit of wiggle space already, you know, in there. I don't know, but everyone does it differently, whatever you're comfortable. So you just go right to, if you're doing an implant there, Amir, you just go right to sectioning, pretty much, premolars, molars.
It depends. It depends.
Without
on,
elevation.
I would say if I have a very thick buccal plate and it's like a single rooted tooth, then I'll just put a narrow beak forceps on it, just small little circular motions, and kind of hold the tissue with my fingers. So I'm not putting any expansile like forces on the plate. But if it's like a premolar double rooted, then I try not to put a forceps, because it's easier for me to section that tooth and remove it in small fragments than to go back and graft that buccal plate.
Makes sense.
That's nice. I mean, you guys are used to direct vision a lot too. I don't really use that often anymore since dental school. Every once in a while to get a root tip out, but not consistently enough, you know. What I found with indirect vision though is, you know, like when you're in the office and you're trying to take photos of the arches and you have those bigger mirrors, right, to get in there and take the reflection pictures. I use those a lot of times for root tips. Instead of the little hand mirror that you're holding there and you're shaking it, it's tiny little window. Sometimes I'll put that big ass mirror in there. I feel like I can hold it more still, and it has a wide viewing range, so you don't have to be exactly with your hand mirror like in the right spot. I've used those mirrors quite often for those situations, not for taking photos, but for indirect vision. I don't know if anyone else does that.
Well, I'm gonna definitely try that.
Good idea.
That's a fantastic idea.
Good idea.
You know what I mean? I feel like it's easier to hold a lot of times. And it's not even that wide. Some of them you can get the mirrors are like just for the buccal and they're like this wide, but versus the ones for the whole arch, whatever ones you have, I feel like I just throw that in there and it's just easier for me to
Serv, I know you're close to my age, but just going direct vision and looking up in there, that'll wreck you for the rest of the day. Amir, you're young. You don't have to worry about that. But it's, oh my gosh, my back can't take it.
Well, the other day, I actually had a premolar that the root divided into 3 separate roots. And the endodontist said, I can't treat this. Like, we can try, but he's like, it's not going to work. Like, there's no way.
It's a little molar. It's a little molar. Yeah, I've seen those. I've even seen canines with 3 roots like that.
And I was planning on doing an immediate implant in that socket. So I went really conservatively. I sectioned this thing, and then I got to the roots, and I'm like, where do I begin? One's this way, one's that way, one's
Did you
that.
know
It's
it
like
was
you're trying-
rerouted before you got down there?
Yeah, we had a CT because I guess the dentist that wanted to do the root canal couldn't do it, send it to the endodontist. The endodontist did a CBCT, and then they saw that it actually tripods from the main root. And then there was a little bit of interseptal bone there between these reroots that I could have engaged for my immediate. So I'm like, okay, let's attempt it as an immediate implant. I got in there. By the time I removed these 3 roots, and I had to use indirect vision because I couldn't see inside that socket. By the time I got there, there was like no interseptal bone left. I had to drill it all out. And it got to the point where I'm like, I just want to finish this extraction. Screw the implant.
Yeah, it's a graft and come back. That's a graft and come back. You always got to prepare them. It's, we'll try. If it's good stability, we'll do it. If not, we're going to come back. Yeah,
What's
that's
your go-to implant, Amir, for your immediate implants?
I used to do Straumann, sometimes Straumann BLX. Now I'm using Straumann BLC for like 90% of cases. It's a really good hybrid implant.
Okay. Aggressive threads, I take it.
It's not as aggressive as the BLX because one of the criticisms with the BLX was the threads were so aggressive that you kind of get some pressure necrosis of the bone around there. So a lot of people, like a lot of specialists, started kind of shying away a little bit from the BLXs, and then the BLT was just too plain of a thread. Wasn't great for your immediates. So the BLC is kind of a hybrid. It's not as aggressive, but aggressive enough that you get primary stability for your immediate implants.
Okay. How about you, Serv?
It depends on what the dentist prefers. We generally have like Nobel and Straumann in the office. If it's Nobel, it could be active or parallels generally. Straumann, we have a lot of BLTs. We have BLX as well. I don't know if we have BLCs actually, but it's usually BLT or BLX if it's Straumann.
You should try it. You should try the BLC.
Just another thing to order. I don't know.
I agree. My thoughts exactly.
But you know what? The great thing about the BLC is then you don't have to order a BLT and a BLX. You can just stock on a BLC, and you can use it predominantly for all your cases.
Yeah, maybe. The BLTs have been a workhorse for years, though. And then I've had good results with Nobel as well. And so, I think we have enough. I mean, people request it. I'll definitely do it. But I don't know. I can go either way.
How about you, Joe?
Pretty much the Nobel Active is what I use. I typically use Implant Direct, but as far as for immediates, which I'm doing mostly now as immediates, the threads they don't engage. They're not as aggressive. So it's really the Nobel Active is what I prefer. I've also started placing Ditron, which I've had some decent luck with it as well. Kind of like a $200 implant, but I think they go in nicely. And a lot of the referrals who have restored them have had no complaints. So, those are the two for immediates, in my opinion.
Yeah, I mean, the overhead costs for any office is usually staff and then like implant stuff. I feel like is
Right.
like your overhead is that for like a huge percentage of it. Especially if you're doing full arch cases, you got to have so much inventory in your office to like do those cases. Like it's crazy. You got to have every size diameter for every case, one up, one down. You never know what you're going to use sometimes, right? I've been performing full arch dental implant surgery since 2012. I started back then with Nobel implants, and I continue to use them today. Getting consistent results over time and seeing these restorations in function over that length of time has basically strengthened my use of the product. There's over 100 implant systems out there. I just choose the one that's been the most consistent for me. So what other complications we got there? We had some good stuff there.
I think
like
the
dry
next
socket.
one-
Let's just do dry socket because that's like super common. I've even gotten referrals like the dentist took the tooth out and they've seen him a couple times. It's just not healing, and we get those kind of referrals. So let's just say, Joe, you take out a lower molar, lower first molar. Patient comes back in 4 days. Open socket, bones exposed, and a lot of pain. What's your protocol for those cases?
First of all, I really kind of confirm whether it's a dry socket or not. But for the most part, I'll believe the patient, and I'll tell the patient. I say a lot of times your soft tissue looks good, the site looks good. It's really what you tell me more than anything, because
Yeah, you're not going to really open it up and look in there.
not really, and you can really diagnose an alveolar osteitis over the phone. You know, it was good for the first 3 days and I fell off a cliff and it was awful. So right there and then you know, but people a lot of times will come in and say, hey, I looked in there last night and I think it's a dry socket. So you got to kind of fish that out first. You know, when they see something, you say, look, it has nothing to do with what you see because it's going to look good. It's how you feel. So say I confirm it's a dry socket, we'll irrigate it one time and then we'll go ahead. We've got the paste.
What do you irrigate it with? What do you irrigate it with?
Just 50-50 mouthwash and water. Just really, it's just more the physical cleaning more than what's it contains, in my opinion. So salt water would be fine. But we use mouthwash and water 50-50. And we've got a little gel foam with the dry socket paste, and we'll just put that in there. So
what kind of paste? What kind of paste is it?
And that's
Socket.
I'm embarrassed to say I don't even know the brand, but it's what they
okay.
sell.
We use Socket. It's called Socket.
Oh, I've
paste.
seen that.
It comes in like a monoject looking thing. SOCK hyphen IT, I think, Socket or something like that. Yeah, it's literally all we use.
The other thing is, and this is how I manage it. And the other thing is, as soon as I put that in there, if there is immediate relief, then you can confirm it was a dry socket, right? If you pack it and the patient says, I still hurt, you know, it's still the same as when you came in. I'll say, well, what you're experiencing is normal post-op surgical pain. So you really didn't have a dry socket. I'll put them on a Toradol or a narcotic and just give it time. But to me, the symptoms going away immediately is almost confirmation.
Amir, you do anything different?
Pretty similar. For me, it's usually after day 3, 4, all of a sudden my pain started going up. And then as soon as I hear the word, I feel like it's radiating to my ear. And then what I usually do is very similar to Joe. I take a cotton applicator and I put some topical on it and I apply it inside the socket. And as soon as they say that the pain's gone, I kind of know it's a dry socket. And then I use Alva gel usually in there. So,
Nice.
and usually they get immediate relief. If they say no, it's not getting better, then I know it's something else going on.
I think that's kind of cool. Like, I didn't think about putting topical in there. What if we can mix that with a socket and just put it in there right away?
I do that. I actually
might be a good
soak
idea.
some of the Alva gel in 20% benzocaine and then put it in there. It's like ice on fire.
That's a really good. I don't even know why. We just literally just put the socket in, and that generally works. Yeah, so like that, I think that's a really good idea. And the other thing with that is, actually, before I get into that, like that's kind of what I do. I put the socket gel. We put the socket gel in there. We have them bite on gauze on the socket for about 15 minutes, and I say just keep biting on that, let it soak in there for a while. Don't rinse the socket out for a couple days. You know, just let the gel work. In really bad cases, I've even put the socket gel on a gel foam and then put the gel foam in there coated with it, so it lasts a little longer, I think. So we've done that at PASS, as well. The other thing is patients don't like to take a lot of responsibility, like if they smoke or use a lot of nicotine, because that can cause a lot of dry sockets and pain, post-op complications. And so a lot of those patients that do it, I do remind them that, nicotine's still in your system even a few weeks when you stop. And that may be contributing to some of the, the longer lasting pain. But I found that they kind of say, yeah, but they still are mad or something. Like they're not taking full responsibility of the nicotine in their system either. So
I've got a hack for that.
What?
So if they're a smoker, I'd never blame the patient ever. I'll tell them this, so to me it works. I'll say, hey, you're a smoker, but you not smoking has really helped. It could have been worse. And they smoked, right? so you just say, hey, good job not smoking. You've done everything right. And then they're saying, yeah, I did do everything right. And then they hurt, they leave, and they don't blame you anymore. So
you're using reverse psychology.
It works.
Joe reverse psychology.
Yeah.
That's a good
idea.
Sure.
Try that.
Imagine if you were smoking, how bad it would be.
Exactly.
When you leave the room.
Right.
I usually just tell them beforehand. I really set that expectation, and especially when they come and you see all that keratosis, like the nicotine keratosis in the mouth, and you can smell it on their breath that they've just smoked a pack before they've come in. I say there's a really high chance you're gonna get dry socket, and if you can avoid smoking for the next 5 days, you'll really reduce that chance. So after day 3, 4, as soon as they get the pain, they're like, yep, you told me I'm gonna get it. You were right.
Right.
Yeah, if you tell them that stuff ahead of time too, like, you remember that convo we had? But yeah, it's really hard for people to quit and stop before a procedure. I get that. But again, it's still a contributing factor in a lot of cases. And I tell people with dry socket, like, it really just delays your healing by about a week. You definitely have more sensitivity or pain. You're still going to heal the same in the end, but it definitely does delay it.
Now I have a question for you guys regarding that. What is your take on nicotine gum? Because that's like one of the first questions they ask me.
Same thing, it's nicotine. So in my opinion, it's nicotine in your system. It's a systemic thing, and then you're going to get vasoconstriction, things like that. So, yeah.
Yep. And that's an oral surgery board question.
Oh, it is?
You don't
Yeah,
remember?
nicotine is
I wouldn't
nicotine in
know.
my opinion. Yeah.
I got that on my oral boards. Okay, well, why? Why is it bad? And just like you said, systemic vasoconstriction for up to 60 or 90 days.
A long
That
time.
can affect, I mean, if you go to a plastic surgeon and you're getting, like a woman's getting their, like a
Facelift
breast
or
hug.
something.
Yeah, some plastic surgeons won't do it unless they quit smoking.
Nope.
For
or
so
even
they'll
a month or
have
two before. Like,
Yeah.
it's legit,
Yeah.
an issue with wound healing. That's how
Right.
that's how long it's in your system. So yeah, dry socket's a thing. They're still going to happen. You take out enough teeth, you're going to see enough of those things. I get that. What about what you mentioned, bleeding?
Bleeding, I think that one has come up like 30 times on this list.
Yeah, so I've made a couple of videos on how I manage some localized bleeding, and what I've done in real time is you're taking out a tooth, you're doing a little buccal trough or something, or you get into the bone. A lot of times it's a bone bleeder, meaning there's a little vessel in the bone that's not necessarily the main artery. It could be a little branch off that, a little branch off that. These intraosseous vessels, they're so tiny, but they can pump out a lot. You see the little pumping sometimes, like you can see it pulsing, right? And it just takes a little bit of that blood just to fill up your whole site and make it a pain in the butt. And the other thing is when you get into that little bone bleeder, right away that vessel is going to retract back into the bone. So the thing is with those, like if you put gauze pressure on it, a lot of times you're not going to stop it. And if it doesn't stop with gauze pressure, it's just that vessel is so far in, you're just soaking up what's coming out. You're not putting pressure on it to stop it. So what I've used in those cases that just doesn't respond to gauze pressure, like literally me holding the gauze down is, with good force, and I can still see the blood welling up around it and suctioning around it. I take everything out, I put bone wax in, occlude the whole socket with it, basically. Some people say just burnish it, but it's really hard to, when it's
you can't
bleeding like
see.
that, to like burnish it. I just throw the gob of it in there and then just, occlude the whole thing. And that'll stop it for the most part. It should. Because it doesn't have anywhere to go in the socket. If it can't get out of it, then it's going to wall off and back itself and then hopefully form a clot. What about you guys?
That's great advice. I picked up something there. I do have bone wax. I use it occasionally, but I've always had luck with just pressure. It's, a test of wills. For 10 minutes, if you just do it repeatedly, I find it'll stop.
Yeah, I just don't like holding a gauze there for that long and just watching it bleed around it.
It's nerve-wracking for sure, but it'll stop eventually, and then maybe some gel foam, and then a suture primarily.
Well, you've been lucky, Joe. I've gotten to some ones that just don't. It's just too much.
Yeah. Right.
Bone wax. As soon as you put it in, you get it occluded. You don't have to hold anything. You just let it hang out, and just let it work for like 5-10 minutes, and then take it out and then check it.
Never thought of occluding the whole site. That's a very good. I'm going to try that.
Yeah, bone wax is cheap, man. I just, we have it in each op just in case, like a pack of it. And then if we need it, we need it. And most of the time we don't. But yeah, I just freaking throw the whole gob in there and use your finger to like, burnish it down in there and smooth it off. And you don't have to hold anything. You just wait for that vessel to occlude. I don't know. What about you, Amir?
So I would say 90% of the heavy bleeds I've had, I was able to manage with gauze. And I guess this is advice for my GP colleagues that kind of don't have a lot of the specialty products in their office. And sometimes you take a tooth out and all of a sudden you just see pump of blood coming from that socket, just filling up the mouth. It can be very nerve wracking, especially you guys, your residency, you guys have seen your share of, gunshot wounds and facial traumas. So it's just another day in the office for you. But for a lot of general practitioners, seeing that much blood in one place, I've had staff pass out on me as it's happened. So they're not prepared. And I think for me personally, 90% of cases, I take a hemostat and I take my 4x4 gauze. I lock in the tip of the gauze to the hemostat, and I start packing it right in, like just packing it in there. Sometimes I might have to like pack 2 gauze in there. I find usually after 5 to 7 minutes, it slows down to the point then you can kind of start looking, seeing where it's coming from. If I've got electrocautery or laser, I might try to, burn the part in the bone that's bleeding. Unless it's at the impacted third, then I don't do that. Then my second go-to is I take a carpool of Lido with 1 in 100 adrenaline. I soak my gauze with
I do that
Lido.
too. I do it all the time.
Then I go back in and start packing it with the Lido.
I always soak it, yeah. I just squirt a bunch of local on it with Epi, whatever you have, and then just use that as a pack. I try that all the time first. If it's still an issue, still taking too long, then I go right to the bone wax and just get it done and then wait. I've even had to take the bone wax out once and then a couple times where I take it out and it starts to rebleed and I have to put the bone wax back in and wait another 5-10 minutes. Take it out and it rebleeds and I'm like, you know what? I'm just going to leave the wax in. I'm going to see you back in 3 weeks and we'll take the wax out. And that's fine then. I've had to do that a couple of times just because it's just not going to stop.
Well, you had a really good video, I think, last year or the year before where you had troughed and you got that heavy bleed from that.
Yeah, it just started the buccal trough really and it wasn't even that deep. And it just got into a little bone bleeder. I mean, little, but it just wouldn't stop with gauze pressure,
No,
I think it was under local too. And the guys, that's a lot of blood going in there that they're going to have to like gargle around and it's not comfortable. When you're putting that much pressure on someone's jaw and they're awake and it's just not. So the bone wax helps.
Yeah, I bought a pack of bone wax since you made
Keep it
that.
in your bag.
Yeah.
Keep it in your, you got to keep it. It's cheap and just freaking keep it with you, It's one of those things. I like it. It definitely has its place, especially if you're taking teeth out. But if it's a small bleed, like gel foam in the socket, like sometimes you take a wisdom tooth out or something, and it's just bleeding a little bit more than normal. Even after you put the stitches in or whatever, it's still coming out. Like a gel foam in there, a lot of times, hold pressure works fine. Those types of things. People on blood thinners, direct anticoagulants, things like that. You can code for a hemostatic dressing, and we do that on those cases, and then just put the gel foam in there with a transexamic rinse. We mix it in the office pretty easily. They don't have to buy it necessarily. They can buy it through us or through the pharmacy is fine. And then we always have in the office if we need it. We can just mix it up really quickly and just use that. So I don't know. Do you guys use that in the office?
Yeah, that's code 7922.
Yeah, the hemostatic dressing code.
Right,
Say it again.
Right. So that's 7922.
Yeah. I mean, you don't get paid a lot for it, but you're using something, you should code for it. And so that makes sense.
Oh, for the
so
first 10
anyone
years
on
of my
blood
practice,
thinners will use that.
I would just give it away, but if
yeah,
you
we
get
did it for
reimbursed,
so many years. We gave it away, and I didn't even know there was a code for it.
Yeah, completely.
I do it for free. I don't think we have a code for it.
Oh, really? Look it up, hemostatic dressing or something like that. I would assume they have it because everyone's on a blood thinner, pretty much. It feels like. But yeah, no, it's helpful. Just
it's justifiable even if the patient is on aspirin, and I'll code for it. I'll put gel foam in there.
Mm-hmm. Yeah,
I usually like to squirt it on my collar plug or gel foam and then put it in. I find it's like so effective.
Mm-hmm. No, yeah, it's helpful. We never take anyone off blood thinners. Like I don't take anyone off blood thinners for anything, and so I just manage it locally, like that.
You ask for an INR, ever or
on warfarin patients? Yeah, we get them a day before, just because it fluctuates so much.
Yeah. Okay.
Yeah. What else is on the list? We're almost done.
Ankylosis, dislodging of a root into the sinus, tuberosity fracture, root fractures.
So if you're taking a tooth out, Joe, and a little piece of root, like a couple of millimeters, pops into the sinus, do you go right after it, or do you kind of manage it and say if anything happens, we can address it then?
Typically, I'll go after it. To be honest with you, just yeah. I mean, if
you would go through the extraction site and try to suction it out. If that doesn't work, your lateral window into the sinus.
Yep. Yeah, for the most. So it hasn't happened very often, but I just think that I think odds are it's going to be okay. But if it's not, then I think it's a bigger problem overall. So I think while the patient is there, while the patient is numb, I don't think it's going to migrate too far. And it's really not that hard to get into the sinus and just put your suction there and look for it. It's adds another 10, 15 minutes to the procedure, but I'll typically go for it.
If it's a 2 or 3 millimeter root, you'd still go for it?
Pretty much. pretty much. I think those might be the more problematic ones, in my opinion.
Interesting.
But even
Yeah.
if sometimes if I, like, for example, I don't mean to change the question, but if it was on a lower, if it was 2-3 millimeters on a lower and it was near the nerve, I'd leave it in there.
Yeah, I agree with that.
Yeah.
I do that, if that happens, you got to weigh the risks with that, because is it riskier to drill around there and potentially cause a permanent issue versus, yeah, if it's in there and a bone grows over it, it's just a little piece of tooth fragment, that's fine. Treat it like an impacted tooth. Or if they get an infection and it kind of migrates off the nerve later and you still have to go for it, it's still less risky permanent wise, in my opinion.
Right. That's
kind of how I
exactly
feel
what
about cornectomy, same kind of thing. So, yeah, they taught me in residency, like, go after every root tip that breaks, but in clinical situations, I don't necessarily do that anymore. And just because I found that you're going to create a lot of collateral damage in a lot of cases just doing that. And you just got to weigh each patient scenario differently,
How many patients do you see from other doctors who have got little root tips in their mouth that are from 20 years ago that they didn't
Oh, yeah, I
even
mean,
know was
they
there?
can be stable for a long time,
Yeah.
obviously. People do root banking, they do all these things, right? I mean, it's just,
So
it's been proven it's not necessarily going to be an issue. So that's why, but I don't know. Amir, what about you?
So usually, I don't know what it is, but it just hurts my ego when I leave a root. So I'm like 99.9% of cases I'm after them, unless I'm worried about like a bad complication. Like if it's next to the nerve, I don't have a CT, or I'm scared of it dislodging into the sinus, or I'm scared of it dislodging into the submandibular space, then I'll be like, ugh, okay, I'm gonna be upset tonight, but like it's better to be upset at this level than to dislodge it somewhere. But if I dislodge a root into the sinus, I usually try to retrieve it through the socket. A trick one of the oral surgeons that trained me when I had first graduated was I pour saline into there and then put my suction right next to the saline and create this little flow of irrigation, and usually you find the root just comes back to the opening and you just pull it out with your suction. But if I have to go through a lateral window, I won't. I'll leave it in there. I had a patient once come out and says, "Oh, I sneezed it out last night and here it is." I'm not joking.
Nice.
Yeah. So
That's
I
cool.
leave it in there, and then if it actually needs to go, like if you have to create a lateral window to go in and get it, I usually refer it, because here in Ontario, as a GP, if you get into any kind of complication, let's say oral surgery complication, even if, let's say, a specialist was to have the exact same complication, the same patient, I will be treated very differently than the specialist would be. So sometimes I just have to choose my battles wisely.
Yeah, that makes sense. Total sense. Yeah, it's a lot of times, if it's a small piece of root, I'm not necessarily making a lateral window right then. I'll follow them clinically. If there's any issues, then we can do it. I haven't had any issues having to go back. I've definitely made lateral windows to get root tips out from dentists that have pushed teeth or roots in there before that have become problematic, and I've had to do that. And I've had some videos on it showing how I did that too, actually. But so it definitely is a thing. But yeah, that's always going to be a tricky situation. The other thing you had mentioned, Amir, like when you're taking an upper wisdom tooth out or an upper molar out, and that tuberosity starts flexing or it breaks off with the tooth, what do you do? Those are some bad ones. Like some of those upper molars, you start elevating and all of a sudden it's not moving, and then you're like, oh, it's really moving. It's nice. And you put your forceps on it and you realize the whole freaking tuberosity is attached. And it's pulling on the palatal tissue. Every once in a while you could get like a palatal laceration because of, you don't realize it, or it's just too much tension there. And then you have to close all that, right? So that's definitely a thing. And I've had referrals for that. Like they've tried to take the tooth out and there's this palatal laceration. I've even had, elevated teeth before and it wants to come out that way. That's a tricky situation. In my opinion, like if that tuberosity is moving and the tooth is out and it's attached to a lot of that periosteum, I'll try to leave it in there and suture around it and let it reform. Obviously, if they're completely fractured and just hanging around, you probably have to get that piece of bone out. Smooth everything down and try to get some primary closure back there. I don't know. What about Joe? What do you like to do?
I agree with you. Like a bigger tuberosity fracture, I think there's more of a reason to leave it in there because of all the soft tissue and all the vasculature of the upper jaw. So chances are it's going to be fine. But if it's if it's a smaller one and you can kind of look and see the size of it, I'll probably dissect it and remove it. So it really depends on the size.
Yeah.
And
If it's got enough attachment, I'll try to leave it in there
yeah, same.
just to reform.
Same.
Amir?
So I actually had one the other day. A patient was like in their mid-30s, deeply carious, upper 8. It had 4 roots, long roots, and one of the dentists wanted to take it. She broke the crown, and then she sent it to me to remove it. And then as soon as I got in there, as soon as I used the spade just to get into the mesial to see if I can elevate, and all I saw is boop. And then there's a whole fragment right behind the tooth moving.
Mm-hmm.
I tried to remove it. It had a significant amount of attachment to it still. I don't know if it was broken from beforehand and then sent to me, but
yeah, probably.
I just take scissors and
Yeah.
just dissect all around it and twist and turn and removed it.
Yeah.
Luckily, I didn't get any tears in soft tissue, but like it was a good chunk. And then I put a couple of collar plugs in there and then try to suture it closed. But they're never fun. I find like, especially with like certain ethnicities, you're more prone to get them. Teeth fully in occlusion, almost guaranteed to get some sort of tuberosity.
That's why erupted teeth can be harder. They look easier, but those teeth are, upper erupted wisdom tooth can be very difficult.
Especially if the patient's like a bruxer and they're like, over 30, you're going to get some sort of tuberosity. And like, I think I learned this from Joe, but correct me if I'm wrong, but a lot of times with those teeth, when I had seen you take them out, you actually make a sulcular incision on the palate too.
Sometimes I'll extend it towards the palate, but yeah, in the sulcus and the palate, yes, especially if they're older.
Yeah. Ever since I started doing that, I find it avoids those palatal tears, like I would say majority of the time.
Yeah, because that attachment sometimes in older patients is low on the root, and that'll still be adherent when its tooth is moving, and then you try to pull it out, and that little attachment is still there, and you just, at that point, you lacerate the tissue. What I do on erupted thirds on older patients especially is I take the back of my, my Woodson elevator. It has like a little tip where you can use your number 9 periosteal. Get distally to that crown and just kind of wedge it in that PDL space to try to widen it and separate that attachment and see if I can, from the tuberosity, basically. I'm trying to use an instrument. I know they have other instruments that are angled better for that. I just use what I have, but yeah, that's what I do too, just to helpfully, not get a tuberosity fracture. Yeah, this is the Woodson elevator. It has this like little tip at the end of it that has this little angle to it. So I just use that curved end of it and just kind of get it to try to create a little space there before I start elevating. I don't know, just in case.
Now here's a question for both of you.
Yeah.
When, let's say you put a forcep or you elevated the upper wisdom tooth and you got a tuberosity fracture, it's mobile, it's like very mobile, but you know it's a big attachment behind it. Do you guys just leave the tooth in there and suture and stabilize it, or you still try to remove the tooth?
Try to remove the tooth.
Yeah, same.
And
yeah,
so
because you're removing the tooth for a reason, and you're leaving it in there potentially now with another complication that, they came in for the tooth. I'm trying to get the tooth out, and then we have to also deal with the sequelae of that. I don't want to. They're gonna have to come back and get it done anyways at some point. So
that's right.
Yeah,
and when they come back, it's not necessarily going to be better. It'll be the same.
So then how do you leave the
circumstances.
tuberosity in there? Do you just use your burr and separate the tooth from the bone?
Sometimes, I've done that where I feel like if there is a big tuberosity fracture, I've taken a drill, if I can get it angled the right way, because I have straight drills, not like you guys. But if I can get it in there at the right angle, you just drill into that bone and just take out, you're not drilling, you're not troughing around the tooth in the bone, you're troughing in the bone, like away from the tooth a little bit. So you keep that little piece of bone on the back of the tooth, but you're just getting rid of the rest. I've done that. I've gone back there as far as I can. And, at that point, you're taking away a little bit of bone, but it's better than taking all that tuberosity out.
Joe, I know you use like the same handpiece as me. What burr would you use in that situation?
Probably the number 8 round. You mean to separate the bone from the wisdom tooth?
From the tooth.
Probably the number 8 round. I think a Fisher may be better. I just don't think it would be that big of an advantage, so I probably would stick with my number 8 round and just try to create a trough and maybe grab the tuberosity with maybe some rongeurs and then the tooth with another instrument and try to separate it so as to preserve the tuberosity and then try to suture it back.
Two-handed extraction?
Well, I mean, if it was in that situation where, yeah, I mean, there should be a code for that, by the way.
Let me tell you something funny real quick. I had it like 15 years ago. I had a dream, and in my dream, I was taking out a 3-unit bridge, both abutments, and both abutments had to come out, the 3-unit bridge. In my dream, I had both hands on 2 different forceps, and I was doing them at the same time on both abutments, and it worked in my dream. I was like, oh, why didn't I ever think about that? And I woke up, I'm like, if I ever get a case, I'm gonna try that. I did try it once on another 3-unit bridge, and it didn't work. But it's like, that would make sense. You're just kind of both hands working at the same time. Your assistant's retracting everything. I'm not retracting with my other hand. I'm using both hands on 2 different forceps, trying to get it. In my mind, it worked, but real life, it didn't work that day.
Your assistants are retracting, and they're thinking, what the hell is he doing?
I told them. I told them I had a dream.
Yeah.
And this worked in a dream, and I'm just going to see if it kind of works, and it didn't.
Yeah.
But had a section in it or whatever. But I tried. It was fun.
Do you have
anything
2
else,
assistants,
Amir?
or do you have 1?
For local, we have 1 assistant. If we're doing an IV sedation, there's 2 assistants.
How about you, Joe?
How about you?
Same. Usually 2. I think the standard of care is 2. So with sedation, you have to have a head holder and somebody assisting you. So yeah, but for a local, just 1.
Yeah.
Okay. Just checking.
Want to do one last one?
Sure.
What's a good one?
Let me have a.
And if you guys are listening and you have more ideas for complications or stuff you want to hear, just let any of us know. We'll try to get another list together and see what people want to talk about.
Management of patients on anti-resorptive medication.
Oh, that's the gray area, in my opinion.
Yeah.
So bisphosphonates, things like that.
Yeah, the Denasemab and bisphosphonates and.
Yeah.
I was actually telling this to Joe. I had one the other day, and for the first time, I decided to refer.
Let me tell you one scenario that I was a part of. Dental patient went to the dentist for removal of a lower incisor. A lot of periodontal disease. The tooth was actually super mobile. Like you could take a gauze and kind of wiggle it around.
Just soft tissue attachment.
It was just barely hanging on at that point. Fosamax, things like, inner system. And the dentist was like, this is just literally there. I can take it out with a gauze almost if I wanted to. And so they did it. The whole thing, the tissue retracted, bone was showing after that extraction and everything. And then he's like, oh man. So he sent the patient to me for management at that point. So it can happen with a super periodontally involved tooth. Like that, it was crazy. Like I saw the x-ray. I was like, nobody would refer that out if the patient wasn't on those medications. But even with that, like it didn't heal well at all. So it can definitely happen. So it's interesting. But go ahead. You were saying, how do you manage those, Joe?
So, yeah, go ahead.
Or Amir.
No.
You had to refer
Joe.
one out.
I had to refer.
Yeah, so, we had that conversation Amir, the other day about what I refer out. And I've had a couple of those that I didn't do the surgery, but I tried to manage it short term and it didn't get any better. And I was thinking that patient was trending towards maybe having some like a resection, that sort of thing. So I sent the patient out. But the way if those patients walk into my office, to me, I think that the IV version of the bisphosphonates have maybe a higher rate of the oral complications.
Yeah.
So I'm a lot more sensitive to that as far as what they need and how I communicate with the patient. But the oral, I've never really had an issue with the oral bisphosphonates, to be honest with you. But my experience is I've never really asked for a holiday except for maybe the IV kind. I have maybe asked the patient to wait because they just had an infusion, to wait until later if they could. But for the oral, typically the patient's in pain and it's urgent, and I just communicate the potential complications, and knock on wood, I haven't had any to manage anything that I've done. So holidays for sure on the IV infused bisphosphonates.
Yeah, some of those medications in your system, like 10 years, so even when you stop, they're like still kicking around. Yeah, it's a gray area. You have to manage it patient per patient. And a lot of times, I've done some cases where, they're so high risk that I don't want to take the tooth out. We ended up root stumping and endoing them. And that's less frequent, but I've done that. A lot of these patients need the tooth out for a reason. It's not restorable. Even root stumping, it has a periapical lesion. Like there's something else going on with it that's gonna. You don't want to have them come back with an abscess and then you still have to do it. You know, in my opinion, because that's worse, right? Now you have an infected site, so that you kind of have to have that trade-off, in my opinion. So I pretty much remove them all if I feel like it's, you know, a hopeless tooth, because I don't want to have that risk of them coming back now it's infected and they're still on the bisphosphonate. Now you got to do it.
Yeah, so for example, if a patient comes in for wanting dentures, they need a full mouth extraction, they've got 17 teeth or 10 or 9, I won't do that. If they've got one problem tooth, like you said, that brings them into my office, I'll remove that one, but I won't do anything elective as far as
I do elective. I do those cases, and the way I do those cases is I stage them. I'll take a couple teeth out, follow them for a month, make sure they're healing, and do another couple teeth. I do that, and I've gotten good results just doing it that way. It takes longer, but you know, you're doing it for a reason.
How about for patients that are on the injections like the monoclonal antibodies like Prolia? How do you guys weigh that risk in comparison with the oral and IVs?
Yeah, I mean, it's higher risk in my opinion, right? But if the tooth is hopeless, I still try to have to deal with it because you got to do something.
Yeah, exactly. And if I'm really not sure and I may be concerned and maybe the patient is giving some signals, I'll probably get a medical clearance just as another step to let the patient know that I'm not overlooking it. And then the doctor she'll always say, do what you think you need to do. And that way, God forbid something happens, I didn't overlook it. I looked into it. And they may recommend a drug holiday. They just may recommend getting the patient out of pain. But like you said, the patient's there for a reason, so you want to treat the problem.
Yeah, but I can see if you're a general dentist or restorative dentist, I mean, that's something, sometimes you just don't want to get into the drama of it and be managing these patients, because if they're not healing well, then at that point you might refer, just because it's a pain in the butt to deal with it. So yeah, I agree with that. Just, sometimes it's easier to refer those cases. Like that one example I told you, that periodontally involved lower incisor did not heal well, and that was a problem. And it took a long time to manage that, even though it was just hanging there, and anyone can just take it out. You still got to deal with the post-op. Any last one you want to do? Then we're gonna shut this thing down. There's some good stuff in here.
Let's see. What else?
We'll need a part 2 for sure.
Oh yeah, for sure. We spoke about ankylosed teeth. Oh, let's talk about IAN and lingual nerve paresthesia. How do you guys manage it?
Ooh, okay, let's end on this one.
You just did your third molar extraction, and patient calls after 48 hours and says, I cannot feel my lip. What's your first?
Joe's just like Paradex.
No.
Soft diet.
No, man, it's over communicate. That's just kind of and don't ever make the patient feel as if though their concerns haven't been heard. I mean, it's really, they teach you that, I think, in OMSNIC, and that's exactly what I do. So I got that call, this week, and I had my assistant convey the message that it's only been a couple of days. It's hard to say if it's going to be permanent, but because there's swelling, inflammation, that sort of thing. So come in a week and we'll map it. So we'll make an appointment for a week follow-up. And then when I see him on that week, I'll take a very detailed history. I'll map, 2-point direction. I do that. I'll have them come back every week for the next month. And I'll start the appointment with any changes subjectively, and I'll write all that stuff down. And then after a month, we'll kind of go over my pictures on the mapping and decide if there's been changes, then they're not a surgical candidate. If there has been no changes or they're getting worse, then it's probably a good idea that I'll refer you to like a nerve regenerative surgeon. And we've got one in Atlanta who I send to. So it's really a communication thing. And because I think that when lawsuits happen, it's when patients think the doctor doesn't care, because it's going to happen. We're going to get the hard ones for sure. It's just how you manage it and make sure the patient's in the communication loop and feels heard.
No, yeah, it's definitely how you manage it. I mean, you're going to get complications with everything you do in this field. Trust me.
Yeah.
If you do enough stuff, you're going to see a lot of things. I totally agree with that. what I do in these cases is, and what's interesting is I've even taken out, 2 years ago, I took out a lower molar, wisdom tooth. Didn't buccal trough, it was partially impacted, didn't buccal trough, didn't section. I just elevated it out. Like it elevated nicely, I got it out. V3 paresthesia, with the lip, the chin area a little bit, like partial, paresthesia. I'm like, I didn't do anything. Like I didn't like drill down there, nothing, right? It just popped the tooth out. So it can happen, routine extractions, it can happen with, drilling around it, blah, 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 swelling, blah, blah, blah. So it definitely can happen no matter what. I've seen it happen with blocks. People get, numbness after a block or injection, right? That happens.
That happened to me, actually.
Yeah, it happens. It can happen with a lot of things. So there is, and I did a podcast on this too. What I usually do in these cases, the patient comes back and they have a V3 paresthesia or something, what I usually do is I put them on 3 antioxidants. They're over the counter. Get them on Amazon, get them at your pharmacy or Thorne or whatever. One is L-glutamine. The other one is alpha lipoic acid. And the other one is I just put them on a B complex. And if you research those or ask Chad or whatever you want to do, you'll find they have really good data for neurosensory deficits, neuropathies, things like that. And so, and people like oncologists use them on chemotherapy patients that get neuropathy, diabetic neuropathies, things like that, and they have really good data. And they're over the counter. So I have them take 1 pill of each a day, and I reevaluate them in 30 days after they've been on that regimen, and we retest like Joe does. We do the light touch, and or 2-point and, direction is what I do. I just use the Q-tip, and then when I take out the little cotton on the Q-tips, the cotton swab, and I pull it out a little bit, tease it out the top, and to twist it. And with that tiny little thing, I do light touch. Everyone has a cotton swab in their office, or cotton, right? And you can just, you tease it out and you twist it up if you don't have anything, real to do it with, and just do light touch. And you can do some direction, like up, down, left, or right. I have them close their eyes and I go, tell me which way I'm going. And I do it on a part of their face that has full sensation to first, so they know what they're doing. I go, just tell me what I'm doing. Am I going up, down, left, or right? And I just kind of lightly put that cotton swab and like down, left. And then I do it on the part that's affected, and I test that, and I document their response, like 75%, 80%, whatever it is. And then like a little prick. I just break the wooden cotton swab, and it's like a tiny little sharp point that's not going to like make them bleed or anything, but it's a little pokier. And I just kind of, if you don't have any like of the things in your office like that Joe might have, the 2 points or whatever, you can just do a pinprick with that. So, test them and mark it down. And then what I found is those 3 antioxidants, I have had good results with them. I've not had to send anyone out to a nerve, repair, surgery, anything like that, which is nice. But you're still going to see some complications when you take out teeth like that. Doesn't always have to be a wisdom tooth either.
And just because you get them doesn't mean you did anything wrong. So keep that in mind.
That nerve is where it is anatomically. It's just there, and on certain wisdom teeth cases, just knowing that, like if I go in there and I'm taking out the wisdom tooth and I have to tease those roots off the nerve, I see the nerve, it's intact, put some collagen over it. I like to see them as a follow-up to make sure there's no paresthesia. In some of those cases, what I often do is if I have to do it on one of the wisdom teeth, I won't remove the other one if it looks the same on the x-ray. I'll wait for them to heal. If they're fine, we'll come back for that one and tell them there's still a small risk with that one that we get into the nerve like we did with the other one. So I'll electively like not remove both of them if I find the nerve on one of them, just because of that issue. So some people just take them all out, they just deal with it. And me, I'm like, it's not worth it. I'm just do the one if it's because that nerve is right there. It's probably going to be right there on the other one. So I don't really. That's how I usually manage those.
I actually had one that I contacted Serv and kind of got his opinion on it because I know he had a podcast on that episode about the nerve paresthesia. But I actually had it with an infiltration with articaine in the maxilla for a restorative appointment. And the patient called me after 3 days saying, the left side of my face is numb still, like 3 days later. And it lasted for almost 10 to 14 days. But I contacted Serv and I told him what was the 3 supplements that you had talked about. I put the patient on that. I also did like a 2-3 day course of Dex
steroid or something. Yeah.
And then after like 12 days, fully regained her sensation. But for that period of time, the patient was really freaked out. And it was like the last thing I was expecting from like a simple restorative appointment in the maxilla.
Yeah.
That's very strange.
It happens.
It happens though, yeah.
Definitely happens. But yeah, this has been a really good, fun one, guys. I really appreciate you coming out and waking me up at 7-ish on a Sunday.
Our pleasure.
But I'm usually up at 5-ish anyway, so it's fine. But this will be a fun one to go over. And if you guys listening have any other ideas for things you guys want us to talk about or whatever down the line, let us know. But thanks, guys. I really appreciate it.
Appreciate it, fellas.
Thanks for having us.
All right, later.
All right, guys. See you guys.
All right, enjoy. Take care, guys.